All right. Hello, everyone. My name is Rachel Zama, and I'm the Programs Coordinator at the Spondylitis Association of America. Thank you for joining us for this live discussion on the latest updates regarding COVID-19 vaccines and spondyloarthritis. We're welcoming two wonderful guest speakers today. We have rheumatologist Dr. James Rosenbaum. Dr. Rosenbaum is Professor of Medicine at the Division of Arthritis and Rheumatic Diseases, as well as Professor of Ophthalmology at Oregon Health and Science University. And we also have virologist and infectious disease specialist, Dr. Bill Messer. Dr. Messer is Assistant Professor of Medicine in the Department of Molecular Microbiology and Immunology at the Division of Infectious Diseases, also at OHSU. Thank you both so much for offering your time and expertise today.
Rachel, thank you for the invitation.
Yeah, thank you very much.
Pleasure to have you. Okay, so some of you watching today might have seen SAA's first Facebook Live on COVID-19 vaccines and spondyloarthritis in early December. Since then, the two vaccines we're most familiar with, the Pfizer and Moderna mRNA vaccines, were approved in the US, and now we have a third approved vaccine from Johnson & Johnson. So now that people are getting the vaccines, including many people with SPA, we wanted to host a follow-up discussion delving into the latest updates. We will also hear the experience of a person with SPA who has gotten the vaccine later on in the program. Of course, I want to let you know there are still many unknowns and research is still in progress, so some questions may not yet have answers. Please keep in mind that the information provided in this program is based on the best available knowledge that our speakers have today, but you should always consult your healthcare provider about decisions regarding your health, since individual circumstances do differ from person to person. Plus, advice regarding specific medications may continue to evolve as research progresses. So with all that in mind, let's dive in. Okay, so now that those who live with spondyloarthritis have been getting the two mRNA vaccines, the Pfizer and Moderna, what is the latest that you can share regarding their safety and efficacy for SPA patients? And are people with SPA generally tolerating the vaccines well?
So I think, Bill, I'll answer this because it's about spondyloarthritis, but please chime in. I would say the answer is, Rachel, yes, that they are very well tolerated. As expected, a sore arm is very common, and a few people are having systemic symptoms like fever, headache, even chills for a day or two after. There are reports of the disease occasionally worsening after the vaccine, but we don't have data. By that, I mean, we have anecdotes where one individual reports that, but we don't know how many thousands have been vaccinated and how common this occurrence is or is not. What we do know for sure is that the efficacy of the vaccine, all three of the vaccines, in protecting against serious COVID-related illness is incredibly good, better than we anticipated or thought might occur based on flu vaccination working 50% of the time. These work far, far, far better. So, many, many decisions in life involve a trade-off. Should I drive to the neighboring city at 100 miles an hour? I'll get there faster. That's a good thing. But I'll take some risks if I do that. And I would say that vaccinating, taking an aspirin, taking a biologic has a risk and a benefit. And here, so far, what we know about the benefit is much, much, much greater than the risk.
That's great. Thank you so much. So you mentioned some mild side effects. What are the common side effects, especially for those with SPA? And can you also explain what is reactogenicity and how does that differ from actually being sick?
So the most common side effect is clearly a sore arm. And it's not unusual to have some achy muscles, some stiffness, perhaps a low-grade fever, a little bit of headache. Those are common with almost any vaccine. It comes with the territory. When you stimulate the immune system produces proteins called cytokines. and the cytokines cause the fever and the activation that we recognize as flu-like symptoms. So those are common. We don't have data to suggest that people with spondyloarthritis are different from perfectly healthy people, with the two caveats that we haven't studied extensively how the medications affect the response to the vaccine, and we haven't studied extensively how the vaccine affects the disease.
Okay, thank you.
Bill, if you'd like to elaborate at all on side effects, please be my guest.
Well, I think that you really touched on what is the key to the question, which is a lot of what we experience as reactogenicity is also what we experience with illness. It's just when we're sick, we know we're responding to a pathogen, something, a bacteria or a virus that makes us ill. When we get vaccinated and are reactogenic, many of those same stimulations of our immune system actually happen, and so we feel in many ways kind of the same way that we feel when we're sick with something that's tickling those immune pathways as well. The difference is there's something in the vaccine that is stimulating the immune system, but not really going to make you sick. It's not a pathogen, whereas with a bacterial or a viral infection, it is going to do damage in one way or another. That's part of the process of making you sick.
Right. So sometimes we say to our patients, it's a good thing in theory if you did have a reaction, because it means that your immune system was effectively stimulated. And some people believe that the older you are, the less reaction you have. And it's well known that, unfortunately, as you get older, your immune system is a little poopier. It's not as dynamic or robust.
Right. So when a patient is feeling a headache or increased fatigue, that's just part of their body making that immune response to the vaccine. Is that right?
I would say yes.
Okay, sounds great. Thank you so much for explaining. A question that some people in our community have had is, do people with SPA or who are HLA-B27 positive actually have an above average immune response, or is it on par with the general population?
So that's I would say it is on par with the general population, but let me elaborate a little bit more. I trained as a rheumatologist nearly 40 years ago, actually over 40 years ago I began, and we used to throw around a term of autoimmune disease a lot, meaning that our immune system was attacking our body, and therefore the idea was that our immune system was too good. And I think that now we think that the immune system is dysregulated rather than too good. And furthermore, autoimmune means that your body is attacking itself. That happens in Graves' disease, for example, which is a form of overactive thyroid where the body's making an immunoglobulin that stimulates the thyroid. But in spondyloarthritis, if the disease is truly autoimmune, that's not at all clear. There's a big debate. Instead, it may be a response to bacteria that are in the gut or elsewhere. It may be a response to something that's not really part of ourself. And therefore, sometimes we say it's auto-inflammatory rather than autoimmune. So it's not that you have spondyloarthritis because your immune system is overactive. I'd say you have spondyloarthritis because your immune system is misdirected. Now, HLA-B27 is a big clue to trying to understand spondyloarthritis. It's a clue that we've known about for not quite 50 years, and we still haven't quite figured out why. But the theory is that HLA types, like HLA-B27 being one of literally thousands of types, that it may give us some protection. And there's some evidence that your response to HIV or hepatitis C is improved if you're B27 positive. But usually that protection comes with a trade-off of a lesser response to something else. We in the Spondylitis Association have surveyed people to see if being B27 positive made it more likely to get COVID or to get a more severe variant of COVID. And based on responses from 4,000 people with spondyloarthritis, the answer is we don't think so. Now, would a larger study show a subtle change? It might, but at least there was no great effect from HLA-B27.
Thank you for mentioning that survey. That is an important result to share with the community. Moving on from the two mRNA vaccines, the Johnson & Johnson vaccine, or Janssen vaccine, has just been approved, and many people want to know if it's safe for those with SPA. We've heard that it uses a live adenovirus as the carrier for the COVID-19 spike protein, and it would be great if you could just explain in layman's terms what this vaccine is, what it means, and how it differs from the mRNA vaccines.
Sure. It's probably not quite accurate to call the adenovirus vectored vaccines live, but as I describe this, I think you'll see how that understanding sometimes comes up. The basic idea is to take. So first, we can take the similarities that this has with the mRNA vaccines. Inside of the adenovirus particle is DNA that encodes the famous SARS-CoV-2 spike protein, which is the protein that the other vaccines use to elicit immunity to the virus. In the other vaccines, it's messenger RNA encapsulated in a lipid particle. In the adenovirus vaccine, it is a bit of DNA that is encapsulated inside of the shell of a virus. So the reason they choose this shell of a virus, adenovirus, is because these viruses are really good at getting into cells. Their cells are really permissive to these shells attaching to and then entering a cell. What a normal live virus would have on the inside of it in its genetic material is all of the machinery that the virus needs to make copies of itself so that the cell that it infects then produces copies of the virus. Instead, this virus has inside the shell, this virus shell has inside of it really just the genetic information required to make a lot of copies of the spike protein. And so instead of infecting a cell and producing a lot of viruses coming out of the cell, it infects the cell and then it produces a lot of spike proteins. Those spike proteins then get processed by the immune system and presented as a foreign substance that needs to be recognized and attacked, if you like, or neutralized by antibodies. And so the process of making antibodies against that protein is undertaken by the immune system, following probably fairly similar paths that the immune system takes with the other vaccines. And so this is a virus shell that can infect a cell like any other live adenovirus can infect a cell, but it lacks the machinery to reproduce itself. And because of that, we don't call it a live virus. We call it a viral vector. It's a vector that can deliver something else inside of a cell. And what it delivers in this case is again, genetic information that encodes the same spike protein that the other two viruses encode. So that's how this virus works, and it's a principle that was discovered now over 3 decades ago, that these viruses, it's very easy to extract their genetic information and replace it with something else. They're very easily manipulated, and then they are still encased in a shell that's very good at getting into other cells and making copies of whatever genetic information or transcribing whatever genetic information is inside of the virus particle itself. So that's how the virus works, or the viral vaccine, vectored vaccine works, the Johnson & Johnson vaccine.
It's much like the mythical Trojan horse, right?
It is much like the mythical Trojan horse. That's an apt description.
I think that was very helpful too, because we see so many headlines calling it a live vaccine, And people with spondyloarthritis often receive the advice that live vaccines are not quite as safe as killed vaccines. So there's been understandably some worry in the community about this vaccine.
Yeah, yeah, and that's the key difference between the live attenuated vaccines that you hear about, is that those viruses are replication competent. That means they can make copies of themselves. They're just weakened copies of themselves, but they really work by acting like a weak infection. Whereas these adenovirus vectored vaccines really work by just stimulating the cell to produce a specific protein of interest, which is exactly what the other two vaccines do.
Okay. So would you say that these viral vector type vaccines are as safe for spondyloarthritis patients as the mRNA vaccines?
Yeah, we don't have as much information about it yet in large populations as we do with the other two, but the principle of it should make it equally safe. And unlike the Moderna and Pfizer vaccines, this vaccine shell, the adenovirus shell Ad26, has actually been used to make vaccines against Ebola and respiratory syncytial virus, or RSV, with really favorable safety profiles using different proteins inside of them. But our prior experience with the vaccine vectoring other viral proteins suggests that it should be just as safe. And then the experience with the vaccine so far has had a very good safety signal.
That's great to hear. Thank you. And one more question about this vaccine. Is there any greater risk of that reactogenicity, those headache, flu-like, fatigue symptoms with this viral vector vaccine as opposed to the other two?
I don't know that I would say there is any greater risk. I would go back and look at the safety data. When I looked at it a couple of days ago, what I was struck by is how locally reactogenic the other two vaccines are. And I received one of the other two vaccines and I experienced a reaction, and I think everybody I know experienced a reaction. So to say that the adenovirus vaccine would be more reactogenic is probably unlikely. But it is probably equally likely to be at least reactogenic in a manner similar to the other vaccines. And I share Dr. Rosenbaum's sort of impression that reactogenicity is one way that we can objectively know that our immune system is responding to the vaccine. If you're not reactogenic, it doesn't mean that you're not developing an immune response, and that's an important thing to know. But to react is a positive indication that your body recognizes something foreign is there, and it needs to muster an immune response to it.
And of course, we know that the Janssen vaccine is a single vaccine. So by definition, you get 50% fewer injections and therefore maybe 50% of the reactogenicity. Better to experience it once than twice.
Right.
That would be a silver lining. Yes, thank you for that.
And it's especially good because many of our patients are taking medicines that impact the immune system, medicines which they presumably need, but in some cases should be altered or held or reduced in order to optimize the response to the vaccine. So life is much simpler with a single dose than two doses, one right after the other.
That makes a lot of sense. And that is actually a great segue into my next question, which is all about medications. So the ACR, the American College of Rheumatology, recently released a manuscript called Vaccine Clinical Guidance for Patients with Rheumatic and Musculoskeletal Diseases. And this document officially recommends vaccination for rheumatology patients with musculoskeletal, inflammatory, and autoimmune diseases. It also discusses guidance for many of the medications taken by those in the spondyloarthritis community. So a few questions on this. Do common SPA medications make the vaccines less effective?
So wonderful question. Maybe we should go through the common medicines. Many of our patients take non-steroidals like ibuprofen and naproxen. I hope it's okay to use trade names like Advil and Aleve and Motrin. We don't really think that those have a major impact on the immune responsiveness, but I doubt that it's been studied in any detail. Many of our patients take biologics, such as TNF inhibitors, and those have names like Enbrel and Humira and Remicade and Simponi and Cimzia, and now the biosimilars. And then there's Cosentyx as well, which is secukinumab. And those medicines have not been studied in detail for how they affect the immune response to the vaccine. We know that they're working by suppressing our body's immune system, but the American College of Rheumatology said you do not need to hold these medicines or alter these medicines if you're planning to get the vaccine. Sulfasalazine is another common drug, also known as azolfidine. You shouldn't need to hold that. And I think that covers the main categories of medications taken by spondyloarthritis patients. Some of the other biologics, which have names like rituximab and Orencia, are different. They have enough direct impact on the immune response that the American College of Rheumatology said their dosage, or that you should time your taking of medication based on those. I guess I should mention methotrexate as well. So, the American College of Rheumatology made recommendations on the treatment of axial spondyloarthritis and does not recommend methotrexate, but we do recommend methotrexate for psoriatic arthritis, which some people in the SPA community obviously have. For methotrexate, the official recommendation is to hold, methotrexate is a once a week medicine, and the recommendation from the American College of Rheumatology is to hold that medicine 7 days after the vaccine, the dose that would come 1 week after the vaccine. And again, if you're getting two vaccines, either 3 weeks or 4 weeks apart, you would hold the second dose as well. When we surveyed the spondyloarthritis community, I would estimate that only 5% of our respondents were taking methotrexate. It's, again, the non-steroidals and the biologics, I think, have captured most of the popularity. But if you are on methotrexate, you should alter that dosage.
Thank you very much for that thorough list. Yes.
Sorry. And I should say, when I say should, as you explained, knowledge is in flux, and this is based on expert opinion rather than data. It's based on extrapolations with other vaccines and what we know on how these medications work. We don't really have data as to how the antibody titer changes in response to the vaccine if you're on Enbrel or methotrexate or Humira. And we don't really have data as to what is an adequate antibody titer. So a couple big unknowns, but we're giving advice which we think is sound, but we realize that we need more information.
And would you mind just quickly, in layman's terms, explaining what the titer is that you're referring to?
Thank you. Yeah, I think physicians and scientists easily slip into jargon, so I apologize and thank you for keeping us honest. A titer is just a way of describing the amount of the immune response. So the vaccine is designed to have your body make antibodies, which are products of white cells called B lymphocytes, and it's also designed to make your body make another kind of an immune response called a T lymphocyte response. But the one that's easiest to measure is the antibody response. And if we are able to dilute your liquid part of your blood, your serum, 1,000 times and still detect the antibody, we would say you have a titer of 1,000. It's the quantification of your immune response.
Okay, that's very helpful. Okay, and then so just to summarize, the ACR basically said that if you're on a TNF inhibitor or an IL inhibitor, just take them normally, but the JAK inhibitors and the methotrexate, those should be delayed. Is that all a fair summary of what you just said?
Yes, and I'm glad you mentioned the JAK inhibitors because the commercial names for those are Xeljanz and Rinvoq and Olumiant, and they are gaining some popularity. They're approved. Um, I don't. They're approved. I think for psoriasis. They're approved in some cases for inflammatory bowel disease, and some of our patients were taking those, and those block multiple cytokines, these proteins in the immune system that are used for communication, and they should be held. And I actually have the printout in front of me. I have to look up, but I think it's to stop them for a week after the vaccination.
Got it. That's great. Thank you so much. So there was a recent study in the Journal of Virology that suggested that NSAID use might dampen the body's immune response to the vaccines. What is your opinion on that? Should people be stopping their NSAIDs or changing anything about their taking of NSAIDs?
That's a Dr. Messer question. Bill?
I'd have to look at the paper to see what exactly the claimed effect is, and specifically what the magnitude of the effect is. I think being able to measure something and being able to assess the clinical significance of that thing are kind of two separate ideas. And I, in general, what I have been recommending people do with regard to NSAIDs in the general population is if you can avoid taking an NSAID before or after your vaccine, particularly in the 24 hours. Remember, these are relatively short-acting medications before the vaccine or after the vaccination. Then, if that's an option, go ahead. If you need to be taking an NSAID for a specific reason, my expert opinion, which is limited, like all expert opinions without data, is that while there may be some subtle measurable effect, the total magnitude of the effect on the titer, the antibody titer that Dr. Rosenbaum very accurately described just a moment ago, is probably not clinically significant. And so I wouldn't perseverate on that detail too much. And if there is a demonstrable clinically significant drop in antibody titers with NSAIDs, then prior knowledge probably would have picked that up with the innumerable other vaccines that have been administered over the decades, and NSAIDs have been around for decades too. That hasn't come out as an important finding in the context of other vaccinations, I think is probably the closest thing to data that I can come up with in this moment that says I don't think you need to worry about this overly much. And I would make the same recommendation, which is if you need to take it, take it. If you don't need to take it and you can take a break from it, then do that, and that's fine.
Call me a wuss, but I took them. I think NSAIDs do have some surprising effects on our immune system. So Ray's syndrome, for example, is a serious liver disease that occurs with viral infection, and taking aspirin, which is the prototypical or the original NSAID. So there may be changes that we don't know about, but I intentionally took acetaminophen or Tylenol before each vaccine. And on at least one of the vaccines, I took naproxen after.
Okay, thank you for sharing that. That's very illuminating. All right, so there's another question that we get a lot that I want to make sure to ask, which is what is the risk that vaccination will cause active disease or a worsening of disease activity in somebody living with spondyloarthritis? Can the vaccine trigger a person with SPA to go into a flare?
So, again, I'm aware of anecdotes of that happening. And the trouble is that anecdotes are just that. They're anecdotes of a rare disease called immune thrombocytopenia occurring after the RNA vaccines. And I know of at least one fatality. But if you if you do anything to 20 million people or 60 million people, rare events are going to happen. And so knowing whether that anecdote is truly cause and effect is difficult to tease out. We used to worry tremendously that lupus would flare from the flu vaccine, and that concept, I think, has been abandoned. And while it's possible that you will feel worse transiently from the vaccine, again, the overall benefit is hundreds of times more likely than the downside. And some of the downside might be related to altering your medication if that's what you choose to do.
I see. Okay, thank you. And relatedly, I also wanted to ask about COVID-19 infection itself. Can getting COVID cause an activation of SPA or a worsening of SPA symptoms, or can that infection trigger a flare?
Oh, that's a tough one. Again, we don't have a lot of information. I'd like to believe that some of the best information is from the survey that the SAA, the Spondylitis Association of America, conducted. And that survey, with roughly 4,000 respondents, indicated that people with spondyloarthritis were not more likely to get COVID and were not more likely to get worse COVID. Now, again, an even larger survey might have produced different results. There are some individuals who have been in the news who are what are called long haulers. So a long hauler is someone who gets the flu-like symptoms that you get initially with COVID, and those flu-like symptoms persist. You don't have your usual energy. Some people describe what they call brain fog, where it just seems like, thinking and mental processes are a little bit slow. You may have muscle aches. And we need to study, and we are actively studying those long haulers to try to find out, is the virus persisting? Is there something different about their immune system? Are they continuing to make these cytokines like interferons, which we know cause flu-like symptoms, and we just don't know? And discriminating between the symptoms of being a long hauler versus the symptoms of your spondyloarthritis being active could be challenging. I would love to hear a virologist's impression.
So the overall prevalence of long haul, or I think the official name that we now have for it is post-acute sequelae of COVID, or PASC, is so 10% in the general population. So it's not an uncommon phenomenon. And when you get into it and look at all of the different symptoms, as you started to allude to, they can range from brain fog, which is essentially a neurologic thing, to blood clots in your small vessels, which is a vascular thing, to aches and pains in joints, which might be mimicking inflammatory arthritis. And so how each one of those breaks out is a fraction of that 10%. And so it's going to be harder to say what the total incidence of those things will be in the general population. And I would agree, not treating this patient population, that it's going to be very confounded by symptoms that may look exactly like the spondyloarthritis symptoms, but could be exacerbated to, or not even related to the spondyloarthritis, but related to a COVID reaction. Ultimately, I think for a lot of this, it still is going to come down to good symptomatic management, and one would hope that as strategies get worked out for the general population, those strategies, if they are not redundant with therapy for SPA patients, then also could be potentially effective there. But it's one of the unknowns, and it is about to be very intensively studied.
That's great. I'm glad to hear that there will be more studies. I think that's comforting to our community as well. I do want to ask one question that just came in live from one of our community members. In making the decision whether or not to get vaccinated as somebody with ankylosing spondylitis, has there been reports of how COVID may affect somebody with spondyloarthritis, and if the danger of contracting COVID is greater than the possible effects of the vaccine?
Well, I hope we addressed that partially before, and that is our survey didn't seem to indicate that having ankylosing spondylitis was likely to make COVID, likely to make you more susceptible to COVID, or likely to make COVID any worse. And the vaccine, which, as I think Dr. Messer and I each said, has some risk, but the risk is minimal compared to what we know the benefit to be.
Wonderful. Thank you so much. Actually, one more question that I want to ask with, going back to our previous discussion of whether the vaccine or COVID can trigger somebody with spondyloarthritis. We also got a question, can COVID-19 infection actually trigger the onset of an immune-mediated disease like spondyloarthritis in somebody who did not previously have that disease?
The only example of which I'm aware is several cases of this immune-mediated thrombocytopenia. Thrombocytopenia refers to a reduction in the platelets. The platelets are a type of blood cell very involved in clotting. And again, it seems based on the timing that maybe that is a rare event, but I think the numbers are around 60 million now that have been vaccinated, and you expect some unusual things to happen.
Sure, that makes sense.
Bill,
Okay.
Dr. Messer, has been more intimately involved in some of these vaccine trials, and more personally involved in reviewing adverse event reports. So he might have a different perspective.
I think you and I get the same information as far as vaccine adverse events go ultimately. In looking at them, some of them look as if they are autoimmune mediated or eliciting immune responses that are wildly dysregulated, leading to things like thrombocytopenia and microvascular thrombosis and clots forming in our small blood vessels and things like that. And at least one report of Guillain-Barré syndrome, which we recognize as being an autoimmune or autoinflammatory process. So those are vaccine related. As I heard the question, I also heard asking about the disease or the infection with SARS coronavirus 2, and I don't know that I can disentangle the short and long-term effects of the infection from other autoinflammatory processes, I think there's going to be a lot of overlap between what we classically recognize as autoinflammatory processes and specific long-term sequelae of SARS-CoV-2 infection. And with luck, for what it's worth, we'll probably learn a lot about both because of all of the scientific resources that are being engaged at this moment to understand this disease. There's actually a potential for progress to be made in both fields, I think, because of that.
Okay, great. I would like to talk about allergies, the recommendation to perhaps not get a vaccine or at least discuss it with your doctor if you've had a severe allergic reaction to other things. So I wanted to ask, what constitutes a severe allergic reaction, and how do you know if you might be at risk for one with these vaccines?
So I'll say a couple of things about this. When we talk about a severe allergic reaction in the context of getting advice from your physician around this vaccine, what we're really talking about is the kind of allergic reaction that occurs in the first 15 to 30 minutes after the vaccination, which is usually characterized by a whole host of whole body symptoms, and those often include a high heart rate, changes in your blood pressure. It can be swelling in your tongue, difficulty breathing, wheezing in your lungs, or a very fast onset whole body rash. These are all acute hypersensitivity reactions. Usually they're associated with a specific stimulant. Classically in my world, people describe this when they get penicillin, but in other worlds, people have these reactions to cholesterol medications or to blood pressure medications, and they're all very rare, and they're all usually associated with a specific stimulation. Or antigen. And in this case, I find that both the Moderna and the Pfizer vaccines, and also the Johnson & Johnson vaccine, that those particular vaccine formulations they're not very complicated, but don't typically contain known things that you're going to have a hypersensitivity reaction that you would be previously aware of. And except in very rare cases, I would say even if you've had a hypersensitivity reaction, if you get the vaccine and you're watched closely for 30 minutes, people can respond if you have this reaction, and it's more likely than not that you won't. Overwhelmingly more likely than not that you won't.
Okay, that's great. And as a follow-up, is the risk of allergic reactions any higher with the mRNA vaccines than the Johnson & Johnson vaccine, or are they pretty much on par with each other?
I'm going to go with they're pretty much on par with each other. They've been very rare. And even because of the heightened awareness of this, I think that things that we might not have called a hypersensitivity reaction following vaccination 5 years ago might be getting called out a little bit more quickly right now because everybody is watching really closely for this. But these can also be managed even when they happen. And I think that the benefit of vaccination, except in a very rare, clear, exceptional case, would still outweigh a manageable risk of a hypersensitivity reaction. I'm really curious what Dr. Rosenbaum thinks about this too.
Yeah, no, I couldn't agree more. The reactions have been described. The protocols require you to stay 15 minutes after the vaccine, and it has occurred. But again, there are millions of people being vaccinated. So 1 in a million, it's low.
Great, that's good. Good to know. What do we know at this moment about how well the vaccines stop transmission of the virus? Can vaccinated people, even if they don't get sick, still pass on the virus to others? Is that risk reduced? What do we know about the vaccines right now?
So this is one of the $50,000 questions around the vaccine, and we know that that all of the vaccines fail sometimes, because we know that all of their efficacy rates are less than 100%. So we know that people are able to get the virus sometimes, even when they're vaccinated. And the question is this, like an iceberg where a tip of it sticks above is symptomatic infection, and then underneath it is under the water, undetected asymptomatic infection. And for the Moderna and Pfizer vaccines, that actually hasn't been wasn't studied. But for the Johnson & Johnson vaccine, they did do a sub-study where they swabbed people who didn't have symptoms and just looked for whether or not they were shedding RNA. And they found that viral RNA that could be detected by the SARS-CoV-2 molecular tests. And they found that it was about 2/3 lower in people who had received the vaccine than in people who hadn't. And this is actually the first piece of evidence that has come out that suggests that it suggests two things. You still can get and shed the virus even when you've received the vaccination, but it's going to be at a much lower frequency, and probably also the total number of viruses that you give off are probably reduced. But it is a mistake to assume that you are protecting people from your transmissibility by having received the vaccine. You yourself are protected from getting severe illness by getting the vaccine, but that's a different kind of protection. And so it's an important distinction to make.
But having said that, Bill, my understanding is, one, that the CDC this week said that people who have been vaccinated, if everyone's been vaccinated, go ahead and get together, that it's reasonably low risk. And we all know that COVID causes a spectrum of severity, from people who are asymptomatic, mildly symptomatic, to death. We don't know exactly what explains all of that. There may be genetic factors and other factors, strain differences, but we do think that the inoculum makes a difference. The inoculum is how many viral particles have you been exposed to? To take a bacterial analogy, bacteria, of course, are different from viruses, but we all probably get exposed to a little bit of salmonella all the time. If we get exposed to an adequate number of bugs, our body can't ward it off and we get super sick. It may be that those who have a mild case have been exposed to a relatively smaller number of viral particles, which would go along with the idea that, yes, you might still have a PCR test that's positive, but that test to detect virus is super, super, super sensitive. So just how communicable you are, we don't know. And it may be that if you are communicable, fingers crossed, but it may be that it's going to cause a mild illness.
You're absolutely right. So, and it's even the dose response principle has even been shown for SARS coronavirus 2 in animal models. We know that we give increasing amounts of the virus to a monkey or to a mouse, and they get increasingly sicker. And so it's a principle that we see over and over again in infectious diseases, and it's happening here too. And I agree with the CDC guidance, particularly when everybody in the room is vaccinated. And the concern, really the only concern is that if you take a vaccinated room, all of those people are protected from getting ill, and that's really what we're trying to do here, is keep people out of the hospital and keep people from dying. But it's still possible to carry a small load of virus into a fully unvaccinated community, and then that virus can amplify itself in that unvaccinated community. And so you just have to think carefully about your own movement patterns. If you and your immediate family are vaccinated, you really are all protected. But if one of that person regularly goes into another transmission setting where they're surrounded by people who are not vaccinated, a virus could still move in. And so I offer that as a cautionary tale, not as a strict limitation, but more like a notion that there are still limits to what we're able to accomplish with vaccination, and that we all still play individual roles and have responsibilities of controlling the virus transmission and spread even after we're vaccinated.
And wearing a mask after vaccination, Rachel, is both because, yes, you could still shed virus, but also it's a sign of solidarity. It's being a good neighbor. It's saying to someone else, I care about your welfare, And, I'm cognizant of that. And nobody's walking around with a badge that says, I've been vaccinated. And so it makes you feel good if you're walking down the street and everybody else is wearing a mask. And we are a community. We're not going to conquer this virus unless the vast majority of Americans, the vast majority of people in the world actually have access to the vaccine and take the vaccine.
Right. Thank you for that reminder. On that note, we have heard from constituents who see the headlines that basically say the vaccines are not 100% effective. You might still be able to pass on the virus. So they wonder, if it's not completely effective, then why should I get it? What would you say to those people?
Well, even Johnson & Johnson, which has the seemingly more modest data about getting infected, has incredibly good data about getting serious disease or death. So no one wants to get the flu, but no one, I think, especially wants to die. And so having that protection makes people feel good. I've known many of my friends who have celebrated the day they got the vaccine or a few days after that, getting that vaccine.
For sure.
The feeling of rebirth.
Yes, understandable. Question, if somebody has had COVID-19, should they still get vaccinated? Why or why not?
So the short answer is yes. It never hurts to get a boost, and it will boost. In fact, the current conversation in the vaccine field is, what about people who are getting the Pfizer and Moderna vaccine? If they've had COVID-19 before, can they really get away with just one dose? And the answer is probably going to turn out to be yes, but it unquestionably boosts your immune response. And that this is my expert opinion, but I'm on fairly solid ground here, almost certainly increases the breadth of your immunity so that you are more likely to be protected against variants that are different from the one that originally infected you.
That's great to know. Thank you. I want to ask a question that's kind of a follow-up from our last discussion, where a theoretical idea was mentioned that perhaps those with spondyloarthritis might need to get 3 shots, an extra booster shot, to build up the necessary protection. Is there any new research to shed light on that idea? And as a follow-up to that, is there a way to tell how well the first 2 doses of the vaccine have protected someone through an antibody test, for example? Should a person on a biologic have blood work done after receiving both doses of a COVID vaccine to determine how effective the vaccine was for them and how well they're protected?
Good questions. The American College of Rheumatology dealt with that issue specifically, and they said, don't bother. That there really is no reason to try to measure your immune response. And I'm not aware of any data on the efficacy of a 3rd vaccine for any population, including the population with spondyloarthritis. There is a study in progress on whether a booster of the Johnson & Johnson vaccine would provide additional benefit, and that will be interesting.
Yeah, I agree with that. There's no clear indication that there's a benefit to a third booster dose. And as Dr. Rosenbaum said at the beginning of this call, we actually don't know what the protective titer of antibodies are anyhow. So if you get a titer, we still don't know exactly how to interpret that, except to say that it's evidence that you received the vaccine. But there isn't a whole lot to hang your hat on above and beyond that. And so there's not a decision to be made after getting that piece of information.
Vaccines do vary a lot in terms of durability. So, after you've had your series of polio vaccines, we think you're protected for life. But other vaccinations, like the so-called DPT, we repeat periodically. The pneumonia vaccine, we say you should get a boost after 5 years. And this one in particular it just hasn't been around long enough to know the durability. So I would hope that the companies will collect that data. And if we do start seeing disease among people who've been vaccinated, I think we'll start talking about boosters at 6 months, 12 months, 24 months. Who knows? But right now, we don't think that's necessary.
All right, that's great to know. Thank you. I want to ask another question that came in live. We've covered a few times the idea of whether a biologic can inhibit the efficacy of a vaccine, but can the vaccine actually reduce the effectiveness of a TNF inhibitor or a different biologic, to phrase it differently?
I guess we would capture that if we're seeing flares. And if we're, again, when we did our survey, roughly half of our respondents were taking a biologic and half were not. And if we see greater flares among those who are not on biologics or who are on biologics, it may be that the mechanism is by interfering with the effect of the biologic. We hope to initiate a new survey specifically on vaccines very shortly. But I think it was Shakespeare who said the course of true research never did run smooth, meaning that just because we have an idea and we want to do it and we have the facilities to do it, we still have to get ethical board approval and jump through some hoops before we can get this done. So I'm hoping that we'll roll out that survey in a week, but I'm only guessing on how quickly the ethics board will take to review our ideas and how quickly our collaborators will assist us in posting it on a survey website.
That makes perfect sense. How long do we think these vaccines will protect us?
There's no clear answer to that question right now. That is, as Dr. Rosenbaum said just a moment ago, they just haven't been around long enough, particularly the mRNA vaccines. We really don't know how long they're going to last. And there's only one way to test it, and that is to wait and see and measure both antibodies, but also look at transmission and protection in the community, because that'll be the real signal of how long these vaccines last.
Great, thank you. I want to ask a few more questions that have come from constituents real quick. We have a constituent who gets frequent uveitis flare-ups and takes steroid eye drops to control those. Would there be any red flags as far as whether she should get the COVID-19 vaccine?
None of which I'm aware of. Prednisone is one of the few drugs that clearly diminishes your immune response if the dose is over 20 milligrams, and I'd be concerned about doses over 10 milligrams. But the amount of prednisolone absorbed by a typical steroid eye drop is minuscule, and that can be minimized by pressing your finger along at the corner of your eye for about 30 seconds after you take the drop so that it doesn't get absorbed through the nasolacrimal passage.
Interesting, thank you.
Rachel, I have another 4 o'clock meeting, so I see we have another guest, but I'm hoping that the audience will understand if I excuse myself very soon.
By all means, thank you so much for joining us. This was extremely informative. We always appreciate your presence, Dr. Rosenbaum. And yes, I do want to welcome our new guest. We're welcoming Michael Supanchik, a member of the SPA community and co-leader of SAA's San Diego support group. Mike received both doses of the vaccine a few weeks ago, and so we wanted to invite him to talk about his experience. Welcome, Mike.
Thanks, Rachel. I'm happy to be here. And I actually was on, but for some reason didn't get connected. But anyway, I really appreciate Dr. Rosenbaum and Dr. Messer's review. It's great. I'm now 3 weeks post second injection from Pfizer. And I can report both myself, my wife, who's about the same point, and a good friend of mine from the support group who also is 3 weeks out. All three of us on the first injection noted some site tenderness on the day following the vaccination. Otherwise felt perfectly fine. And on the second vaccination 3 weeks later, none of us felt tenderness at the injection site. However, my wife had a rather severe headache the day following the vaccination. Myself, I just felt kind of down. Yeah, I just felt a little tired and quote brain fog type feeling for about 24 hours. Other than that, haven't had any problems. And the other gentleman didn't have any symptoms following his second vaccination at all. So it actually is, I think I equate the first one especially to being very similar to having a flu vaccination in terms of the response and so forth.
That's great to hear. Thank you so much for sharing your experience. And
Sure.
regarding those brief side effects that you felt, the headache and the fatigue, how long did those side effects last?
Again, the side effects lasted less than 24 hours. So
that's great.
In my case, it actually was the second day, which seems to be pretty normal for me when I have any type of a response. It's usually my second day rather than the first day, but about 24-hour span.
Okay. And I know that you're taking a biologic, so I wanted to ask, did you make any changes to your medication schedule around the time you got the vaccine?
Actually, I tried to space it so I was 7 days, I take it every 2 weeks. So I was 1 week out from my previous injection. I don't know if that made any difference or not, but I just wanted to be evenly spaced between the two.
So you did not, right. So you didn't pause
So I did
or
not
delay.
make any real change, no. And if I pause, I typically am uncomfortable. So I stayed on my regular routine.
That's great. And that does adhere to the new ACR guidelines that we have now. And one final question for you. Did you speak to your rheumatologist or any other physician before you got the vaccine?
No, actually, I didn't. I paid a lot of attention to material that I read that you had on the SAA website, and also what I heard in the news and so forth. And then also wasn't concerned because of it being a mRNA and not a live, quote, live virus. And that's why your coverage today on the Johnson & Johnson was great to know that that isn't an issue either.
Great. Well, thank you so much, Mike, for your time and sharing your
Thank
story.
you.
I think it's very helpful for everybody to hear from a fellow member of the SPA community. So I really appreciate you coming on.
Well, I appreciate your coverage today. It was great. It really was.
Thank you. Okay, Dr. Messer, if you are brave enough to remain on with me for just another minute, I have just a few extra questions. Is that okay with you?
Yes, I can stay on for another couple of minutes. I think Dr. Rosenbaum and I are both supposed to be attending the same seminar. It's on spondyloarthritis and the gut microbiome.
Oh, okay.
So I'll let him represent me there for a couple of minutes more, and then I will go join that talk.
Well, we are so lucky to have you, and this will just be a few brief tie-up questions. So just to cover a few very basic questions that are still kind of floating around out there, you cannot get COVID-19 from getting the vaccines, is that right?
That's right. You can't get COVID-19 from taking the vaccines. And I guess I would add that early on in the vaccine campaign, there was a concern that the vaccines could actually make COVID-19 worse if you got it. And there's if you got the vaccine and then actually got infected. And there's not only is there protection clearly now with the vaccines, but absolutely no evidence that it makes the disease worse.
Okay, wonderful. And is there any new data to share about whether the vaccines are safe for kids under 16 or for pregnant women or some of those other populations that were not included in the original clinical trials?
Yeah, so for kids, there really are no data out there. There were a handful of women who were pregnant and didn't know it, who received the vaccine or had negative pregnancy tests that were false. Or got pregnant in the interval between the first and second dose. There wasn't any safety signal with any of those incidents, and our our understanding of the biology and the vaccines suggests that it should be relatively safe to get vaccinated while pregnant, but I think that's a conversation. I can't make that as an individual recommendation to anyone. I can only recommend that individuals who are thinking about getting vaccinated while pregnant should talk to someone who knows, one of their physicians who knows their medical history and their pregnancy state.
Absolutely. Sounds good. And there is still an idea floating around about whether the mRNA vaccines impact your DNA in any way. Can you speak to that?
Yeah, so this has been both studied in detail, and we know a lot about the biology of RNA and DNA. And there's no mechanism that's ever been recognized in those systems that would allow RNA to reverse transcribe itself and jump into the DNA. And there's no mechanism in the design of the Johnson & Johnson vaccine that would lead to this happening. And for the Johnson & Johnson vaccine, this has of course been looked for with other viruses that the vaccine has been used against and hasn't been seen. And of course now millions of people have received the mRNA vaccines, and we don't see, evidence is a funny thing to look for in this case. It's kind of hard to see, but we don't see any untoward effects that could be associated with that.
Wonderful, thank you. And you did mention that you yourself got the vaccine, and you had a positive experience?
Wait, absolutely. I positive. I had the same emotional response that Dr. Rosenbaum described in terms of a sense of relief, and I also had the same reactogenicity that people have described. I had fatigue and arm pain for a couple of days after both of the doses, and knew that my immune system was responding.
Wonderful. Thank you for sharing that. Okay, we are past the end of our program. So I want to thank you so much, Dr. Messer, for staying on this long. And also a big thanks to Dr. Rosenbaum, who had to leave a bit earlier. Your participation in this program is so very appreciated. And thank you, everybody, for spending your time with us today as we all work to stay informed and educated. You can find more resources by visiting our website at spondylitis.org/coronavirus. We hope this was very helpful for you, and please reach out to SAA anytime if you have questions. So thanks again. We hope you enjoyed this program.
Bye-bye.
Bye. Thank you.